Assalamu alaikum wa rahmatullah. We'll talk about laryngeal cancer imaging. I'm Dr.Qandeel, a neuroradiologist and emergency radiologist at the University of Chicago and also at King Hussein Cancer Center. I'm also the CEO of MedOne Academy. These are the parts of our talk today. We'll talk about some anatomy, we'll talk about imaging techniques briefly, and we'll talk about laryngeal cancer staging through cases. Then we'll conclude. So head and neck anatomy is complex. It's a small part of the body with a lot of complex anatomy, and sometimes minor details in the tumor extent can affect management options and also outcomes. So optimal imaging is essential. Relevant history is also essential. We need to know exactly the patient's history, what have been done and will be done to the patient. We need to know the exact clinical question and provide details that would actually help manage the patient optimally. We need always to review the original study and the progression of the disease if we are doing follow-up scans. Sometimes, given the complexity of the imaging and the details, we need to focus on one step at a time, do a systematic approach, and maybe even ignore the obvious pathology initially. Laryngeal cancer represents 1 to 2% of global cancers. The vast majority of these are squamous cell carcinomas and are associated with tobacco and alcohol consumption. HPV, unlike head oropharyngeal cancer, is not an important causative agent. Laryngeal anatomy, generally the larynx is the part of the respiratory tract between the pharynx and the trachea, and it's bordered by the hyoid bone from the top side and by the bottom of the cricoid cartilage from the lower side. It is composed of an osteocartilaginous framework in blue, also muscles, fat, and neurovascular structures, which are mainly the submucosal structures. And then we have the mucosa covering all these structures. When the patient is examined clinically, the mucosal surfaces is what they see. Most of the submucosal structures are not very amenable to clinical assessment, and that's where imaging becomes really important. If we look at the osteocartilaginous framework of the larynx, we have the epiglottis, we have the thyroid cartilage, we have the cricoid cartilage, and then we have paired arytenoid, paired corniculate, and paired cuneiform cartilages. For the imaging anatomy, if we look at the sagittal imaging, this is the larynx magnified, and this is a drawing. So this is the epiglottis, and the epiglottis can be divided into the suprahyoid epiglottis and the infrahyoid epiglottis. And we have anterior to this the pre-epiglottic space, which is an important space because involvement can affect management. This space is bordered by the thyrohyoid ligament anteriorly, mostly composed of fat. And then if we look on coronal imaging, we see this is the true vocal cord, which is composed mainly of the thyroarytenoid muscle, or the bulk of it is the thyroarytenoid muscle. And then we have the false vocal cord, and in between we have the laryngeal ventricle. If we look at this space deep to the mucosa, this is the paraglottic space. And the paraglottic space in the upper larynx is mainly composed of fat, while in the glottic larynx, it's mainly composed of soft tissue, predominantly muscles. We have the thyroid cartilages, the hyoid bone, these are the valliculae, and this is part of the cricoid cartilage. This is on sagittal and axial imaging, and you can see how the adducted vocal cords are difficult to assess compared to the abducted vocal cords, and that's why when we image patients we ask them to do quiet breathing rather than breathing or breath hold, because breath hold would do the adduction and make the assessment really difficult. These are different axial images from the supraglottic larynx all the way to the lower or subglottic larynx, and this is at the level of the true vocal cords. Again, sagittal imaging, the epiglottis, pre-epiglottic space, true vocal cord, false vocal cord, the laryngeal ventricle in between, the thyroid cartilage. This is the cricoid cartilage, and this is the hyoid bone. This is on coronal imaging, and we can see the paraglottic space more clearly. As we said, in the upper larynx, it's predominantly fat, easy to assess. In the lower larynx, or in the glottic larynx, it is mostly soft tissue and can be difficult to assess by CT. And that's where the role of MR becomes really important. This is going more posteriorly, and you can see these are part of the cricoid cartilages, and these are the arytenoid cartilages holding the true vocal cords, and this is the cricoarytenoid joints. These are different axial images in the upper larynx, and you can see CT and MR, how MR provides a little bit more soft tissue contrast. This is in the level of the glottic larynx, and you can see how the paraglottic space is predominantly composed of muscle. And this is in the lower larynx. So the larynx is divided into the glottic larynx, supraglottic larynx, and infraglottic or subglottic larynx. And the glottic larynx is essentially the true vocal cords and the anterior and posterior commissures. And then the supraglottic larynx is the epiglottis, the false vocal cords, the ventricles, the aryepiglottic folds, and the arytenoids. And the subglottic larynx extends from 1 centimeter below the true vocal cords to the bottom of the cricoid cartilage. This is on sagittal imaging, again the glottic larynx, the supra and infraglottic larynx. We'll move to the submucosal structures. Accurate radiologic assessment is important because it affects T classification and also affects treatment planning. We'll divide these into paraglottic space, preepiglottic space, and laryngeal cartilages. We'll start with the paraglottic space. Invasion is classified as T3. Also, involvement of certain parts of the paraglottic space, namely the thyrocricoarytenoid space, is associated with poorer outcome and also can affect treatment planning. The paraglottic space is like a highway for submucosal tumor spread. In the supraglottic larynx, the paraglottic space is mainly composed of fat and is also continuous or partly continuous with the preepiglottic space. It is easy to assess by CT or MR because it's mainly composed of fat. If we go to the glottic larynx, the paraglottic space becomes predominantly soft tissue in composition and therefore is more difficult to assess by CT, and MR is superior to that. The posterior part of the paraglottic space at the glottic level is the thyrocricoarytenoid space, which we already mentioned its significance for treatment planning and outcome. The tumor spread in the paraglottic space craniocaudally, but it can also spread laterally through the thyroid cartilage or the thyrohyoid or cricothyroid ligaments. It can also spread anterior-posteriorly. If it spreads posteriorly, it can involve the piriform sinuses, the cricoarytenoid joint, and the posterior thyroarytenoid muscle. We'll move to the preepiglottic space. The preepiglottic space, invasion of this space is considered T3. The degree of invasion can affect the surgical options. This is the preepiglottic space. It's mainly composed of fatty tissues and some connective tissue and blood vessels. These are two examples, coronal stere imaging showing tumors with fairly sizable or submucosal component. The first one is extending through the cricothyroid ligament into the extralaryngeal soft tissues. You can see the tumor here. The second case, the tumor is extending after invading the thyroid cartilage and also through the thyrohyoid ligament into the extralaryngeal tissues. Compare the left thyroid cartilage lamina, which looks intact, to the right, which shows abnormal signal and is also morphologically abnormal. We'll move to the third part of the submucosal spaces, the laryngeal cartilages. Invasion of the inner cortex of the thyroid cartilage is classified as T3. Invasion of the cricoid cartilage or through the outer cortex of the thyroid cartilage is classified as T4A. Invasion of the laryngeal cartilages affect prognosis after radiation treatment and also affects the choice of surgery, total versus partial open laryngectomy. The problem with cartilage assessment is that the thyroid cartilage does undergo ossification, which can be variable, difficult to predict, and can even vary from one side to the other. This is a histologic image showing the left thyroid cartilage, and you can see here like fatty marrow within ossified part of the thyroid cartilage. This is like the cortex, and this is the hyaline cartilage that is non-ossified. So just like they differ histologically, they also differ by imaging. You can see here in black the fatty signal within the marrow of the ossified part of the thyroid cartilage versus the non-ossified hyaline cartilage, which shows dark T1 and T2 signal. On diffusion imaging, the thyroid cartilage, whether ossified or non-ossified, tends to show low signal. The invasion of the thyroid cartilage can be variable also. It undergoes initially an inflammatory phase with edema and increased vascularity, then an osteoblastic phase where there is new bone formation. This stage can be mistaken for normal ossification of the cartilage. And then in the third phase, there's osteoclastic phase where the tumor actually causes frank invasion into the cartilage. CT cannot distinguish the first two stages from normal variation in the cartilage, and that's where MR is superior. On MR, hyaline cartilage and the cortex of the ossified cartilage tend to show strongly hypointense T1 and T2 signal and no enhancement. The marrow cavity of the ossified cartilage is just like fat, shows fatty signal, no contrast enhancement. As we said on diffusion, both the ossified and non-ossified cartilage tend to show low signal. Primary and recurrent laryngeal cancers tend to show intermediate signal on both T1 and T2 and STIR and show moderate contrast enhancement. And they tend also to be diffusion restricted. Therefore, MR can distinguish between tumor and peritumoral inflammatory changes and cartilage invasion. The concept of peritumoral inflammation is important because laryngeal cancers can be associated with an inflammatory response. And if we don't try to distinct this inflammatory response from the actual tumor, we can overestimate the extent of the tumor. In general, peritumoral inflammatory changes tend to have higher signal on T2 and STIR compared to the primary tumor, which tends to show intermediate signal. These inflammatory changes also tend to show more intense contrast enhancement and tend to show no diffusion restriction. So if we go to the same previous example, where you can clearly demarcate the tumor here, showing intermediate signal on STIR, compared to the inflammatory changes in red, which tends to be more hyperintense compared to the tumor. On post-contrast imaging, the appearance would also be similar. The same with this case where you see this tumor extending inner and outer to the cricoid cartilage, extralaryngeal extension. This is the tumor extent, as opposed to this abnormal signal here and there, which is an inflammatory peritumoral response. For imaging techniques, CT and MR are the primary modalities. CT used to be the primary modality along with endoscopic assessment and biopsies. It is readily available and relatively cheap. It is fast, so less motion artifact. It provides high spatial resolution and can be multiplanar. It also can be combined with chest imaging to rule out metastases. This is an example of a CT protocol. We want to emphasize the importance of doing quiet breathing rather than breath hold to keep the vocal cords away from each other and easier to assess. MR has replaced CT as the primary modality for laryngeal assessment because it can provide better assessment of cartilage involvement and extralaryngeal involvement. We need to perform a dedicated laryngeal protocol with high-resolution surface codes and parallel imaging. We perform multiple sequences, STIR, T1, T2, and post-contrast, as well as diffusion-weighted imaging to provide multiparametric MR imaging assessment, which can better differentiate between the tumor and the peritumoral inflammation and fibrosis. The disadvantage, the exams are lengthier than CT and therefore more susceptible to motion artifact. This is an example of an MR protocol for initial laryngeal cancer assessment. Ultrasound, mainly used for nodal assessment when combined with fine needle aspiration. PET-CT is reserved for complex and advanced cases, also for follow-up and to rule out systemic involvement. Dual energy CT has some advantages. It can increase tumor conspicuity compared to the usual imaging. Also, you can see here the extralaryngeal tumor is easier to delineate from the strap muscles overlying it compared to the normal CT imaging. It can also minimize artifact. For laryngeal cancer staging, So as a general rule, T1 is when the tumor is limited to one subsite and associated with normal cord mobility. T2 is more than one subsite and impaired cord mobility, but no fixation. T3 is when the tumor is limited to the larynx, but is associated with cord fixation. And T4 is when the tumor extends beyond the tissues of the larynx. We should keep in mind that for T1 through T3, it's subsite specific. So the details of the T staging can differ whether the tumor is supraglottic, glottic, or subglottic. So we'll start with an example of supraglottic tumor. You can see this lobulated mass that does involve the epiglottis. It looks markedly thickened. The tumor also extends into the pre-epiglottic space. And you can see even the tumor extending into the paraglottic space. And here we have the thyrohyoid ligament, and perhaps the tumor is also extending either across or just above the left thyroid cartilage lamina. This is another case where the tumor is involving the pre-epiglottic space. It is hard to assess the anterior parts of the thyroid cartilage lamina given the normal variation in the degree of ossification. It is also difficult to separate the tumor from the strap muscles, so it's difficult to assess for extralaryngeal extension. When you compare this to MR, I think it's easier now to appreciate the advantage of MR, where for example, the strap muscles have a very different signal intensity when compared to the tumor, and you can more clearly see the extent of the tumor relative to the overlying strap muscles. So this tumor has already extended external to the larynx into the extralaryngeal tissues. So this is a T4 tumor. This is T1 and T1 post-contrast. You can see also the tumor and the intermediate degree of contrast enhancement. On post-contrast imaging, you still can easily discriminate between the tumor and the strap muscles. On CT, they all look similar and cannot be distinct. For glottic cancer staging, this is an early stage T1A cancer. These are usually better assessed by imaging, by clinical examination. As we said, the main role of imaging is to assess for the submucosal extent of the tumor. This tumor is involving the anterior commissure, and you see the degree of thickening. It also extends into the anterior part of the left true vocal cord. This is a more advanced cancer that has spread into the paraglottic space. You can see the tumor bulky, also reaching at least to about the inner cortex of the left thyroid cartilage. This is a T3 transglottic and paraglottic involvement laryngeal cancer. This is a more advanced case where the tumor is clearly extending external to the thyroid cartilage lamina on the right side. You can see the tumor similar signal to the original tumor. So this is extralaryngeal extension of the glottic cancer. This is another one where the tumor extends into the extralaryngeal tissues, but with minimal cartilage invasion. And this is a tumor that extends through the thyroid cartilage notch. Subglottic tumor, again, this is another case where you have a lobulated mass that involved the anterior subglottic larynx. This is the cricoid cartilage. And you can see, like, by examination, they will be able to see this component, the tumor, while all this submucosal component is really difficult to assess. If you do MR imaging, you can more clearly see this poorly contrast enhancing tumor, which involves the subglottic larynx. This is a more advanced case of recurrent subglottic cancer associated with cartilage. Due to the limited time, I'm not going to be able to discuss the details of every subsite for T staging. For the nodal assessment, there is clinical and pathologic assessment. What has been added to the clinical assessment recently is the extranodal extension. This is a bad prognostic sign when the lymph node or the tumor is extending beyond the confines of the lymph node into the adjacent tissues. And an extranodal extension positive lymph node can upstage the N status to N3B, regardless of the size or the site of the lymph node. The pathologic grading is beyond the scope of this lecture. For M staging, it's M0 or M1. Now we'll look at a few cases. So this is a subglottic cancer, and you can see the lobulated mass, which shows contrast enhancement. What you can see here is the extralaryngeal component of the mass that goes deep to the uh, strap muscles. Now, this could be through invasion of the cricoid cartilage, or could be invasion through the cricothyroid ligament. You can see here that the extralaryngeal component of the mass has similar signal intensity to the intralaryngeal component, which tells you this is actually tumor extension rather than peritumoral inflammation. Compared to this case where you have an infiltrative supraglottic mass involving the paraglottic space, the left ariepiglottic fold, and at the same time, you see this extralaryngeal mass anterior to the thyroid cartilage notch, which in this case was an incidental thyroglossal duct cyst. And you can see how on post-contrast imaging, it has different signal characteristics compared to the original tumor. On CT, this would be very hard to discriminate from extralaryngeal extension. Now we'll look at few cases to illustrate cartilage invasion. Cartilage invasion assessment can be tricky given the normal variation in ossification. It is important to make that distinction because it makes a difference regarding management options and T staging of the tumor. MR is definitely more sensitive. The criteria has been revised a few times to better discriminate between invasion of the cartilage and peritumoral inflammation. So the component within the cartilage or external to the cartilage has to have similar signal intensity to the or the rest of the tumor on T1 and T2 on post-contrast imaging, as well as diffusion to increase the specificity of the assessment. For example, this case where you have a anterior supraglottic tumor which infiltrates the paraglottic space. Now, if you look at the anterior parts of the right and left thyroid cartilage lamina, you see there is abnormal signal within the marrow of the cartilage. And this is T1, T2, and T1 post-contrast. And you can see that the abnormal signal within the marrow has similar signal characteristics on all sequences to the original tumor. This is actually a true invasion of the cartilage confirmed by pathology, as opposed to this mass where the tumor infiltrates into the posterior paraglottic space at the glottic level. But at the same time, you see abnormal signal within the left thyroid cartilage marrow, lamina marrow, which is on T1 looks similar to the original tumor. On T2 definitely looks different. The tumor has intermediate signal on T2, while this component has really bright T2 signal. And on post-contrast imaging, this component within the thyroid cartilage also shows intense contrast enhancement compared to the remainder of the tumor. So this is an inflammatory process within the left thyroid cartilage lamina rather than true tumor involvement. And this also is a path. On this third case, you can see also a tumor infiltrating the paraglottic space, the anterior commissure at the level of the glottis. The tumor is reaching all the way to about the inner cortex of the left thyroid cartilage lamina. There is also abnormal signal within the marrow of the left thyroid cartilage lamina, which looks a little bit bright on T2 compared to the tumor and a little bit more contrast enhancing. So this is more in favor of inflammation rather than tumoral involvement. Here's another case of right-sided laryngeal cancer where you see a lobulated glottic mass that invades through the right thyroid cartilage lamina with a sizable extralaryngeal component deep to the strap muscles. And you can clearly see how the extralaryngeal and laryngeal components of the mass have similar signal intensities on stir, T1 post-contrast, and even diffusion. And this is a path-proven T4A laryngeal cancer, glottic laryngeal cancer. This is another case with lobulated glottic and supraglottic right-sided laryngeal mass. The mass does abut the inner cortex of the right thyroid cartilage lamina, but the thyroid cartilage, it appears intact. There is, however, a small signal abnormality external to the posterior margin of the right thyroid cartilage lamina. This may represent small extralaryngeal component or may represent an associated inflammatory change. In this case, it looks fairly similar to the intensity of the mass on STAIR, maybe a touch more intense, but it looked a little bit different on diffusion. If you on the ADC, the mass looks diffusion restricted. The lesion external to the thyroid cartilage does not look as diffusion restricted, and this was negative for thyroid cartilage invasion on pathology. These last two cases are from our recently published article looking at the concordance between head and neck MRI and pathology in detecting laryngeal subsite invasion among patients who underwent primary or salvage laryngectomy. We looked at 137 cases, and we looked at each subsite and looked at sensitivity and specificity and the positive and negative predictive values for each subsite. And the results are promising with relatively good concordance, but with variation from one subsite to another. Now, post-treatment changes can be complex also. In general, post-radiation changes include diffuse laryngeal thickening, submucosal edema, fast straining, thickening of the platysma muscles, and hyperenhancement of the thyroid salivary glands, which ultimately become atrophic. This is showing like the diffuse edema and thickening in the laryngeal tissues in the supraglottic and glottic larynx. This is a post-total laryngectomy. You can see the fat within the flap. You can see the neopharynx. There is usually some concentric thickening of the lining of the neopharynx. This is normal. As opposed to this case where you have an eccentric mass-like lobulated thickening arising from the lining of the neopharynx, and this is a recurrence. You can see how this may look okay on endoscopic examination because this is mostly a submucosal recurrence of the tumor. This is another case where there is concentric non-mass-like thickening of the neopharynx lining, but this is too much compared to what you would expect normally, and this was also a recurrent cancer. This is a case we looked at previously, subglottic laryngeal cancer, recurrence with destruction and collapse of the laryngeal cartilages. More rarely, you can encounter laryngeal tumors with intact mucosa, with pathologies like chondrosarcoma and metastases. This is a case of chondrosarcoma and the typical pattern of ossification. This is a larger chondrosarcoma, and the typical appearance on MR, really bright T2 signal, lobulated mass, peripheral contrast enhancement. This is a case of prostate cancer that presented with change in voice, and this is from 2 years ago where the cricoid cartilage looked intact. Now you see this mass arising within the cricoid cartilage causing erosion, and this was prostate cancer metastasis. This is a case of liposarcoma. These are all really rare tumors. You can have diffuse thickening with pathologies like amyloid, sarcoid, TB. You may also encounter hoarseness of voice due to recurrent laryngeal nerve paralysis, as in this case, where there is focal dilatation of the left piriform sinus, the left laryngeal ventricle due to medialization of the left true vocal cord, epiglottic fold, and also the arytenoid cartilage. And in these cases, you need to image the chest. In this case, there is left lung cancer and aortopulmonary window lymphadenopathy invading the left recurrent laryngeal nerve. You may also encounter hoarseness of voice due to a mass, as in this case of glomus vigali tumor, which compresses multiple cranial nerves, causing atrophy of the muscles of the tongue, the trapezius muscle, and also the left sternocleidomastoid muscle. So in conclusion, understanding cross-sectional anatomy is crucial. The majority of tumors are squamous cell carcinoma, and the main role of imaging is to assess the submucosal extent of the disease and anything involvement of any structure that may affect management or outcome. Imaging can help differentiating T3 from T4 tumor, which can affect also treatment planning. MR imaging has replaced CT for the larger part of laryngeal cancer imaging due to its superior ability to distinct between or differentiate between tumor and peritumoral inflammation and to better assess the cartilage involvement. Be mindful of the potential challenges such as small lesions, cartilage, and biopsy changes. We need to embrace a multidisciplinary team approach to know what the other members of the team want to know so that we can provide details that are actionable. Unfortunately, due to travel, I can't take your questions and comments live, but I would be happy to respond on email. Thank you for joining.